Thank you. Thank you for joining us today for this webinar. Everyone, I really appreciate it. We have really a lot of people registered for this webinar. Let me introduce our guest today. He is a well-known person. Dr. Medhat Askar is a well-known person to all of us. He is a professor of pathology and laboratory medicine at Texas College of Medicine. He's the director of Transplant Immunology and Hematopoietic Cell Processing Laboratory at Baylor University Medical Center, Dallas, in the United States. Dr. Medhat is the current president for the American Society for Histocompatibility and Immunogenetics. Dr. Medhat is the member of the National Board of Directors of United Nations of Organ Society, United Sharing. Also, Dr. Askar holds many other advisory and executive roles in transplantation-related societies. And also he is one of the executive board member in the ARSHI. So we would like to take this opportunity to welcome him. Dr. Medhat, you can start. The floor is yours.
Thank you, Fabi, and thanks for the organizers for this opportunity to talk to you and share with you some of the impact of COVID-19 times on our lab and the probably number of labs around the world. I would like to welcome all of you from the tropical beaches of Baylor University Medical Center in Dallas. And this is the beauty of virtual reality. You just make it whatever you like it to be. So just as an outline for the things I will be touching on, I would like to talk a little bit about the impact on transplant immunology laboratories in terms of staffing, operations, and things of that nature. I would like also to talk about assays specifically that has to do with viral detection. And I would like to talk about immune responses to SARS-CoV-2 infection. And I'd like to touch very briefly on research initiatives in relation to COVID-19. So one of the things that we typically talk about in accreditation and at times of inspections and in quality meetings and things like that, but not day in, day out, every minute of the day, is safety. So safety become front and center in everything we do since we are dealing with this COVID-19. And this new concept that there are a lot of measures that you take to protect others rather than protect yourself. And protection of yourself comes as a side product of everybody else protecting you. So it's something a bit different that we are not used to. And I used to explain to us, of course, by now everyone understands this, is that when you are wearing a mask, it is not going to protect you, because if somebody sneezes on you, the mask is not going to prevent the droplet from infecting you. But what the mask can do is that if you sneeze, then instead of traveling the 6 feet, the mask is going to stop the droplets. And also, now we are concerned about everyone we deal with. We want to protect the staff so that we can provide care for the patients. We want to protect the patients. We don't want them to get infected from us. So it's really something that everybody became focused on. One of the things also, at least initially, is declining transplant testing volumes. And this has led some of the laboratory actually to have a significant reduction in testing volume, and some they had to have their staff work for reduced hours, or sometimes in severe cases, maybe even furlough some of their workers. Another thing is that COVID-19 testing became like a national service duty. So every department of the hospital became so involved in supporting testing or care in different aspects, but particularly for the transplant immunology lab, they were uniquely positioned to support this testing because number of things. We are one of the very few labs that does both molecular testing and antibody testing. Not many other sections of the lab would do the same. Also, we are very experienced in, and when I say we, I use we loosely to reflect the collective of the transplant immunology laboratories. We are very well versed in test development. We typically don't use FDA approved tests. We develop most of our tests are lab developed tests. And since COVID-19 just came about, and the process of getting FDA approval is a very lengthy process and takes months and months, sometimes years. So there wasn't the opportunity to do that. So it became a matter of laboratory developed tests. And that's why the transplant immunology were very adept to implementing this. Also, another thing is that many of the instruments we use actually are very helpful for COVID-19 testing. Real-time PCR instruments, ELISA readers, and readers of all sorts. Sorry. One of the things happening, we dealt with declining transplant volumes that affected some centers more than others, but now we are resuming transplant activities, which really means that we will need our instruments back for our testing. If we used to have other departments use our instruments, we need our technologists back if they used to help with other departments performing the testing. One extreme of this model of support is that laboratories that actually took on COVID-19 testing, like my laboratory at Baylor University Medical Center, where it became the central lab for COVID-19 testing, both by PCR and by antibody testing. So now we had a little bit of slowdown, not much. I'm going to show you the numbers now. But now the transplantation operation is coming back, and we have already large number of our staff tied up in the COVID-19 testing operation, which is kind of a challenge. So this is just to show you, I know you can't read this, but what you can see here is that this is our staffing schedule, and you see something here is the name of one of our team members for every test we perform throughout the week. And that was what our schedule like in January. Fast forward 2 months, this is our schedule after adding ELISA, which now we have 1 to 2 people operating it, and real-time PCR, which is 2 people every day. And actually I didn't include here that actually the COVID-19 testing is 7 days a week. So actually we have people working here as well. So what this resulted is that now what used to be 2 people for some of the tests is now only 1 person. And in many places, it's just we are not sure who's going to do this, and we just play it by ear. Many places, actually, we don't staff it and we let it happen because it's just we don't have enough people. So this is where you just renegotiate with the administration that you need more staff if you were to maintain both operations. And actually, I do very little when it comes to that. I'm very fortunate that I have a group of very talented and dedicated people. This is Lynn Klingman, our lab manager. This is Jennifer Williams, who is our supervisor, who actually now at times she have to come herself at night to perform some of the testing on the bench. And this is Amanda Willis, who also is the lead of the molecular testing. And Amanda actually is one of the rising stars, not just in our lab, but in the ASHI community as a whole. Your administration tells you that the volumes are down, why you need staffing, and why don't you let your people go. This is just what this looks like. I recognize that in some centers the reduction is more than 20%, but this is if we compare January to April. So when I prepared the slide, that was in April, we had 20% reduction. Actually now in June, we are almost the pre-COVID-19 testing level. And you see that really there wasn't that much reduction. Actually, in some instances, there was increased. We noticed that many centers that really shut down their operation completely resulted in many organs, deceased donor organs becoming available. So since we were open for business, we took more than we normally would be available to us. Live donor in some centers stopped completely. In our center, just declined a little. In hematopoietic transplant, it wasn't affected that much. But also more important than this is that if you are running 2 or 3 antibody testing, or if you have 50, the staffing is the same. You just have to, we don't have the luxury to accumulate them until we get a 50 and run them because of the turnaround time. So really sometimes the 20% reduction doesn't translate necessarily to decrease staffing needs. And this is something that we need to explain it clearly to the administration. During this preparing for the COVID-19 testing, we acquired a good amount of automation. And here you see this is Hamilton StarTech that we just got during this. Now everyone is wearing masks, and you can tell those who are working with live virus, they having N95 mask. Everybody else, they can do whatever they want. And the only time we can let go of our mask is when we are on conference calls or YouTubes or Zoom or whatever you may, which we do quite often these days. We became familiar with things that I don't know, we haven't been exposed to before. So this EUA process, which is the emergency use authorization. So basically when we developed these tests, and you just send an email casually to the FDA, and you tell them, oh, by the way, I'm gonna start testing tomorrow. And you just don't tell them much about the test you're gonna do. And they send you an email and say, yeah, go ahead. And you start testing, but within 14 days, you send them a very abbreviated version of validation. Way less than anything we would do for any test that we normally do. We also, I became very popular at the medRxiv website, which is a website that houses preprint publications, meaning publications that have not been subject to the review process, the peer review process. So these have not been accepted in any journal or even reviewed by any journal. They could be at different stages of the submission process, but they don't have to be. They could just never progress to that. So these things actually get circulated among people without necessarily people paying attention that this has not been reviewed. So some of it is very high quality from very prestigious groups and end up shortly to become in the published domain, but some of it do not make it. Some of them have serious errors. So just be careful of that. This seems to be common in other fields other than medicine, like informatics, engineering, but now it seems like we are getting introduced to this as well. Now, if before I talk about testing for COVID-19, I just probably by now everyone has become COVID-19 expert and they don't need to belabor this. But just a reminder, since I will be referring to some of these points during the presentation so that we are all on the same page. So this is the genome of the COVID-19 virus. It's about 30 kilobase. So it is really not huge gene, and you have these are the components of the genome, the viral genome. You have ORF 1A, open reading frame 1A and 1B. You have here the S gene that encodes the spike protein, which has two subunits, S1 and the S2. You have the E or envelope protein, and this is the E protein. And you have the M protein, and you have the N or nucleocapsid protein. And this is the viral RNA. So that's why it is a good idea that you use assays that test for multiple genes. And I'm going to show you in a minute why this is. So this is an example. This is our negative control, the MS2 gene, and that is going to be present in every assay regardless of the results, so that you know it's positive, and you know it's positive by having exponential phase that looks like this. And this is the cutoff that shows you anything that crosses the cutoff becomes positive. And here are all other three genes, the N gene, the ORF1AB, and the S gene. Sometimes it is not that clear. Like, for example, this test, it's only one gene that is amplifying. This is the negative control. This is one gene is amplifying and having very high or very late. So the smaller the number of the threshold cycle, the curve is going to come here. The late is going to be here. And we can see that this is 38. And the PCR reaction stops at 40 cycles. So it actually, if it was just a little bit later, it would have been counted as negative. And it looks like there may be an exponential phase. So what do we do with that? Is that positive or negative? So we have this interpretation chart, and we say that when you have only one target gene that is positive, amplifying, and it is late, more than 35 cycles, then we repeat in duplicate to make sure if it is positive or negative. And here we can see clearly that when we repeated it, it became clearly negative. One of the things you hear about is cross-reactivity, where this is coming from, because there is, if we do sequence alignment, so here you see that the percentage of amino acid identity of coronavirus spike and nucleocapsid proteins of the SARS-CoV-2. And if you compare them to SARS-CoV-1 that caused the SARS epidemic or pandemic in 2002, you find that there is 90% amino acid sequence homology in the N gene. It gets less a little bit in the S gene, but the S2 subunit actually is not that different. And it gets still significant amount of homology with the MERS, the Middle Eastern respiratory stress syndrome, and the other human coronaviruses, and even coronaviruses that are from the Alpha family, which is the distant cousin of the COVID-2 virus. And that's why when we look at ELISA reactions, you see that if we look at the IgG, you find that this is the true positives. These are the SARS-CoV-2, but you see good amount of positives in the COVID-1, and actually you find some in the other coronavirus families. So this is something we need to be very mindful of when we interpret the results of testing. Also, there is all kinds of pre-analytical issues. If you look based on the specimen type in patients who are hands down having COVID-19 testing by imaging and by clinical and by every other measure, we still find that there are the most commonly used form is the specimen type is the nasopharyngeal swab, and we find that it is positive only in 63%. The sputum is 72. And of course, the lower you get in the respiratory tract is bronchoalveolar lavage, it becomes up to 93%. But you see that in feces, it is 29%, in blood, it's 1%, in urine, it is not detected. But be mindful that if you read 10 papers that talk about the subject, you're going to come up with completely, sometimes overlapping, sometimes different, sometimes completely different numbers, just by the virtue of how novel this is and how it is still so much unknown about it. This is another interesting thing. What does it mean to be positive? Or I showed you the threshold cycle of 35 or 38. I told you that this means it is really very low, right? And anything here, if you see, if you have very high amount of the very high viral load, and that gives you positive at cycle only after 13 cycle of the real-time PCR, or up to 17 cycle, then 100% this is gonna grow in viral culture. But if you go down, the further down you go in, let's say, the higher the threshold cycle, the lower the starting viral load, the lower the probability of having growing in a viral culture. And we see this, that after 34 cycles, usually it would not grow in viral culture. Another thing very important is that this is question of if someone has been infected and they had the symptoms and they cleared the symptoms and they remain positive by nasopharyngeal swab, they found that even if they are positive, it is not necessary that they're gonna grow in viral culture. And in one study, anything after 8 days of symptoms could not grow in viral culture. We talked about real-time PCR, which is by far the most commonly used technology in the present time for COVID-19 testing, RT-PCR. But also there are studies that looking at using high throughput next generation sequencing. And really it offers, think of it this way, imagine the difference between the HLA typing we do by real-time PCR or melting curve analysis versus HLA typing by next-generation sequencing. When you do HLA, when you do COVID-19 testing by NGS, you achieve two things, at least two things. One, you can do sequencing of the whole genome. So if there are any mutations that could be associated with different susceptibility or different severity or whatever the case may be, you could detect those by next generation sequencing. Also, you can do, so actually it's a three advantages, not just two. The second one is that you also get the chance to do viral load quantitation. So you can actually count the number of copies that are there. Third, and really very important, is that the high throughput, you can test 1,000 samples per run. I think the most highest throughput, if you were to use on real-time PCR, the 384 well plate format, then you would test 380 or something, because you would have some controls as well. So it is going to be significantly. So why it is not popular? It seems like it's an amazing thing. One, the level of expertise required to do this. Two, the equipment are not as commonly or as affordable as the real-time PCR equipment. And another thing actually is the turnaround time. Turnaround time is, so the real-time PCR is about 3 hours. the next generation sequencing because of the library prep and the PCR and the sequencing time, at least it is going to be 18 hours or so. And if you have a patient waiting in the ER to be triaged, however, to go home or to be admitted or to be isolated, you cannot wait for that long. So these are challenges that perhaps we're going to get over recently. This is really very interesting study that explains, shows, demonstrates the utility of next generation sequencing in this. It's by Ayan Hossein from Pennsylvania State University. And just the top panel, it shows that after extracting the RNA of the virus, you barcode them, you index them, and that before you run the RT-PCR reaction, so that you are already from here, you start the multiplexing. And from that, you pull them into, because they are already barcoded, you can pull them. So the concept of pooling in infectious diseases and in blood banks is not foreign. We always used this, but we used it in what seemed creative at the time, but seems so primitive now, is that if one of the pools come positive, we go back and test every single one of them individually. Now, because we use indices and barcodes, we don't need to do that. After pooling, we still know which sample came positive. And then we run them in a regular next generation sequencing platform. So this is, you can see if this is patient 1, patient 2, patient 3. So we barcode each one of them with a different barcode. And then after we index, we barcode them, we pool them, and then we sequence them using next generation sequencing. We could even add another layer of multiplexing. I showed you that the percentage of testing of nasopharyngeal swab is not 100% of oropharyngeal swab, is not 100% of sputum, nasal aspirate is not 100%. What if we were to pool different specimens from the same patient so that we maximize the probability of detecting when it's positive, we actually can detect it as positive. Now, let's talk a little bit about antibodies. Antibodies also has its own challenges. And if we, everybody talks about the vaccine, that all our problems is going to be solved when we have a vaccine. That's predicated on an assumption that a vaccine is going to do a number of things. One is going to enable us to make neutralizing antibodies. Because if we don't make antibodies, that's not good. If we make antibodies that are not neutralizing, that's not good either. But it turns out even to be a bit more complicated than this. We want antiviral antibodies that are neutralizing and actually target epitopes that are the binding sites to the ACE2 receptor, which is the viral entry receptor, so that it blocks the viral from entering it. Of course, just neutralizing the virus could be effective, but it would be more effective. And the animal models have shown that the viruses, the antibodies, the neutralizing antibodies that that bind specifically to epitopes associated with binding of the ACE2 receptor are the most protective. Also, the antibodies, as you may know, that at the end of severe cases, of the end of the spectrum of severe cases of illness with COVID-2, they are associated with cytokine storm. So with release of inflammatory cytokines like interleukin-6 and the others, so these antibodies not only gonna block the virus, but also they gonna dampen the activated macrophages and neutrophils, so it quiet the cytokine storm. Also, something that is good and bad. Some of the other antiviral antibodies that we may have due to vaccination with measles or otherwise actually may cross-react with the virus. So they could potentially confer some immunity, but they are also problematic for us for when we are developing assays that we have to, that may give us false positive. This is Immunology 101, right? That we expect that you have the symptoms due to viral infection, inoculation here, and then at some point you develop IgM, but it's short-lived, and then it goes away. So it starts from day 7, go away by day 21, and somewhere in the middle, let's say day 14, we start developing IgG that is gonna continue on and protect us, right? That will be really great. But you will find publications in studies, very well done studies in very high profile journals like Nature Medicine that shows, well, not exactly, because you could detect IgG as early as day 2, and you could detect IgM as late as, actually in other studies, it's shown that up to after 28 days. So this is a problem, because it really tells us that we cannot use, or at least with the information available to us, it doesn't seem like we can use antibodies to diagnose or to as a diagnostic tool to help us determine what phase of the disease the patient is at. So when we think about antibodies, we really need to think about the context of testing. So are we doing this as a diagnostic? It doesn't appear like antibodies, with the information we have, seem to be very helpful when it comes to diagnostics. What about screening? It is complicated, because I showed you that they can appear as early as day 2 when the patient, and I showed you in a previous slide that if you have the virus, it still could grow in cultures and consequently infect people up to day 8. So basically, seeing IgM or even IgG is not in isolation without doing anything else, doesn't tell us that this person is immune or is not carrier. It doesn't tell us if he is asymptomatic. It doesn't tell us if he can infect others. It doesn't tell us that if we were to admit him to the hospital, the staff taking care of him do not need protective equipment. So it is complicated. Staff, that's another problem. I don't think it is legitimate that we enforce testing every staff, because people would worry that this may be used against them in staffing decisions. Say, okay, you are infected, you're gonna stay home, or things of that nature. So the programs I'm aware of that in screening programs, they have number of protections. One, they make it voluntary, so it is not everyone is forced to do it. Two, it is the results do not get shared with the managers or any staff health or any administrative body in the hospital. It's only shared with the patient and their primary care physician, and no staffing decisions can be made based on this. That seems well and good, but it creates a problem, another problem. Patient's gonna say, wait a minute, you are screening me and you are not letting me get my operation or whatever you're gonna do with me, and gonna delay my elective procedure, and you are letting your staff do it whenever they feel like, and even if they are positive, they don't have to tell you. So it's all kinds of problems that we are dealing with. Antibodies also, are we using it for characterization of convalescent plasma? And I know the Professor Dr. Ashraf Dada gave a very elegant talk about this, which really makes me don't want to show of my ignorance more than I have to, but I will touch on brief points as pertains to testing. Response to vaccines. We said that we're going to give people vaccine, so what happens? We need to make sure that they develop the antibodies, that these antibodies are protective, and that these antibodies are durable. Because if I give you a vaccine that's going to make you make antibodies for only 3 months, that's not very helpful. And the other context for testing is epidemiological, which really seems the safest bet for this. If you test people, like 10,000 people, and there are some false positive and some false negative, they're probably going to cancel each other out, and it is not going to affect significantly the prevalence of the virus. Some institutes like ours, they use what we call combined testing strategy for screening patients. So we want to test them by IgG, IgM, and PCR. So because we don't know which one is going to be positive when, and we want to make sure that if they are positive, not necessarily that we're not going to treat them or anything, but we want everyone dealing with them to be prepared with appropriate protection. This is actually a study that shows number of patients. If you look at IgG and the IgM and the PCR, you can see some of the patients remain PCR positive well above 1 month. Antibodies, they appear early, they appear late, they don't. So it is, it is what it is. And also there is another problem when they talk about onset of symptoms, right? This is our landmark. What is onset of symptoms? I mean, the symptoms could be any myriad of varieties of clinical pictures. It could be fever, it could be cough, it could be sore throat, it could be GI symptoms, it could be loss of a smell, it could be completely asymptomatic. It could start asymptomatic, then become symptomatic. So really determination of first day of onset is not easy as it seems when you read these publications. More things to consider. All these tests have sensitivity, specificity, negative predictive value and positive predictive value that is really based on the prevalence, and in absence of knowing, having firm understanding of the prevalence, becomes very hard to determine those. There are these pre-analytical sensitivity issues, like the specimen type and the sample collection technique. Because if the swab, for example, is not collected appropriately, the nasopharyngeal swab, it becomes nasal swab. You saw the differences. It drops from 72 or 63, I apologize, from 63 to about 26. So these are important things. And also analytical sensitivity. You heard about the assays that have false positive up to 50%. And that's especially in point of care testing. So you really need to have a strategy. If the test you're using is having high false negative, then probably you need to reflect all your negatives into a more sensitive method. Post-analytical challenges. In transplant immunology labs, we are spoiled. We are used to have finite amount of people we talk to. No matter how large your transplant program is, and you have pediatrics, and you have adults, you have kidney, you have bone marrow, you have this, you have that, it's still finite number of people. Try COVID-19. You are dealing with everyone in the hospital. All services, all administrators, reporting to all kinds of structures. And we talked about the clinical utility versus epidemiological utility, reporting cases, however you need to report to them. One of the important things is who is the person you need to report to, because you really need to get the information to the person who's going to act on it. Employee screening programs, I talked about this. Immunity, effectiveness, and durability, we talked about this. The convalescent plasma, just quickly, somebody gets infected, they recover, they presumably make antibodies, although not always the case. Then you take their plasma that is contained supposedly and hopefully the virus neutralizing antibodies, although not always the case. And then you can use it for both prophylaxis for people who got exposed but not sick yet, or people who are already sick as a therapeutic. So this is a study, and this is probably the most popular and well-cited study about the using the convalescent plasma in critically ill patients. And you see that it is preliminary communication. You see it is only 5 cases. So the take-home message really is that it is very early to tell. And it's very hard unless it is controlled randomized trial. And they get to appreciate this because we looked at some of the what they call compassionate use, is just give the drug to everyone and hope for the best. Then you find that people who didn't take the drug doing better than those who took the drug. And say, how is that possible? This drug is shown in other studies to be very effective. The problem is, if it is compassionate use, you're probably going to be selection bias. You're going to give it to your sickest patients that may not benefit from it anyway. And also, likewise, if you are using it and you show benefit, it's very hard to tell, because these patients, they may have been the patients who are sick and everything, but they are getting other drugs or other care or other level of care. So unless really it is controlled randomized trial, you can tell. But here is something really, one of the things that pertain to us, why I'm bringing all of this, is that some centers use convalescent plasma without testing. So you have been sick, you have been positive, now you are negative, you're good to go. We're going to take your plasma, we're going to just injecting it in people and hope for the best. Number of studies have shown that not everyone who develop the disease actually develop antibodies, and not everyone who develop the antibodies develop neutralizing antibodies. In this particular study, they used a fairly high titer as their criteria. They used 1 in 1,000. So it needed to be positive in 1 in 1,000 for total antibodies, and the neutralizing antibodies to be greater than 1 in 40. So this is an important point. This is actually a recent article. It actually is going to appear in print in 2 weeks from now, but it has been online for a week or so. And it shows that detection of the virus-specific humoral and cellular immunity in convalescent plasma. And this is what they show. These are the highlights of the study. That the virus-specific antibodies are detected in COVID-19 convalescent subject. Granted that this, I think, was performed on 40 subjects or something like this. Most convalescent individuals have detectable neutralizing antibodies, not necessarily high level. Cellular immune responses to virus are found in convalescent subjects, and that neutralizing antibodies titer correlated with the number of virus-specific T cells. They showed something very interesting. There is this debate. Some of the assays on the market, very popular ones, are specific, exclusively nucleoprotein, and some are what we call receptor binding domain of the S protein, the spike protein, and they showed better correlation with the spike protein, especially if they are specific to the receptor binding domain, but no correlation with the nucleocapsid protein. Now, I want to remind you of how great the invention of monoclonal antibodies is. We can see here that these 3 gentlemen who got the Nobel Prize for this, how that really became one of the significant advances both in diagnostics and in therapeutics. This study, I talked about the convalescent plasma, that not everybody's going to develop antibodies. Not all antibodies going to be neutralizing. But if you take it another level, not all neutralizing antibodies are equally effective in blocking the virus and in protection. So that's why if we can detect specifically these super antibodies, if you may, and we can create hybridomas that make monoclonal super antibodies, that will be really the best for managing the virus. And in this particular study, they identified 6 monoclonal antibodies. 4 of them did not actually neutralize the virus. And 2 of those that neutralized the virus, one of them actually corresponded to epitopes that bind to the ACE2 receptor, but the other one didn't. So the other one was neutralizing and everything, but didn't. And actually, the one that led to that was specific to the binding motif with the receptor actually was the one associated with the protection. Here is another Nature study that demonstrates another 2 antibodies, and actually they took it a step further because the 2 antibodies they identified, they tested them, and only the one that was specific to the binding site inhibited infection in rhesus monkeys in both prophylactic and treatment setting. So really, so think of it, what about those who are not testing at all? If it is complicated to the level that not everyone's going to develop antibodies, not all those who develop antibodies are going to be neutralizing, not all those who develop neutralizing antibodies are going to be protective. Okay, just a few words about ABO. This is interesting thing. There was this report that showed that patients who are O or B actually have lower incidence of infection compared to those without anti-A antibodies, which are groups A and AB. And here we can see that these difference in incidence of the disease or susceptibility to disease actually stimulated others to hypothesize why is that. We mentioned that the virus receptor is glycoprotein, and these antibodies are actually anti-glycoproteins. So hypothetically, these could actually affect them. And here is an opinion paper, so it doesn't have data, but it just proposes a model that if you are a B person, if you are an A person, your virus is going to be coated by glycoproteins of the A, and you will have anti-B antibodies. And of course, you can infect other people with the A. You are unlikely to infect someone with an O, because blood group O, because they have anti-A that is going to attack, that's going to have some protective effect against the virus. And you see that person with O, they don't coat their virus with any of the blood groups. And you can see that the person with AB actually is going to coat it with A and B, but he wouldn't have any antibodies, anti-isohemagglutinin, so he can get infected easily with any blood group. Just a quick thing about therapeutics. The drugs, of course, there is the remdesivir and all other things, but one particular related to testing in transplant immunology labs is the tocilizumab, which is a drug used for management of cytokine storm. It's anti-interleukin 6. And actually, it is one of the drugs that actually used in desensitization of highly sensitized patients. And since this interleukin 6 antagonist, actually one of the diagnostic tests that come with it is the interleukin 6 testing in plasma. And actually, there is a Luminex-based assay for this, just single for interleukin-6, and there are multiplex that test for a variety of pro-inflammatory antibodies. We don't perform this test in our lab, but I know other labs like Dr. John Schmitz in North Carolina is testing it, and the other transplant immunology labs are testing it. Just quick things about what are the opportunities for research that this COVID-19 created. There are now groups that are studying the host genetic factor, host immunogenetics factor, because you cannot completely explain neither the difference in susceptibility, the difference in severity, or even the difference in the spectrum of antibodies, of clinical picture, from GI to respiratory to coagulation, you name it, what it is, based on age or gender or comorbidities or anything that initially thought is. Initially, they thought that children wouldn't get it. Now we see children get it and even get severe cases. So it is plausible that host immunogenetic factors might be responsible. And this is the website of the HLA COVID-19 consortium, and anyone can subscribe and become part of it. And they're working on all kinds of associations, HLA associations, and KIR and otherwise. There is another opportunity through the 18th International Workshop, and you can get more information about this by contacting the project leader, Dr. Parham. I'll stop here and take questions. Thank you.
Thank you. Thank you very much, Dr. Medhat, for this talk. Excellent, very elegant presentations. Probably anybody has a question can write his questions in the chat space there. And I will start with the discussions with one of the points that you, Dr. Medhat, mentioned in that beginning of your talk, which is very important in any for any laboratorian person, which is the false positivity and false positive and negative of the real-time PCR in case of amplification of one gene, like S gene examples. You did plenty of samples. Have you calculate or look at the probability or the percentage of those cases showing false negative?
I would say that so that's the thing. We haven't looked at it systematically. I get asked this question. I just don't get around to do it because it is not a pressing problem. Because for us, anything that we have any doubt, although this, actually, you could auto-verify these results. If it meets the threshold, you could just release it. We don't do this. We look at every result. And if there is only one target, we repeat it. I would say we see this every 2 or 3 runs. So it would be a case every couple of hundred. So it is less than 1%.
Okay. How about, until people raising the questions here, you also touch a point which is mixing sample between sputum and swab, having sampling together. Have you tried that in real-time PCR?
We haven't. Okay. It's just that the trouble, the practical, you see, in theory, there is no difference between theory and practice. In practice, there is. Mm-hmm. Just collecting a sample is really inconvenience to the patient. Whether you're asking him to give sputum or, like, for example, the precautions for saliva. It needs to be first thing in the morning, before the patient brushes their teeth and before they eat anything. And so imagine we're going to ask him to do this and also give a sputum and also stick something into his nose down to his brain. So absolutely. It's really, it's a good tool to have when you have to.
Right, right.
But I wouldn't volunteer my patients to do it.
I see. Okay. Please, anybody in the group, you have questions, please. Here we do have a question from Dr. Latifa saying, your screening strategy is based on association of molecular and serology tests, impact on patient management?
Yes, because if they are positive on any of them, they get in specific places in the hospital. Everyone dealing with them is using appropriate PPE. If they are negative for all three, then the likelihood of them, for someone who's asymptomatic, negative on everything, to be actual positive is statistically very slim to non-existent. So these we treated them like before COVID-19.
Very well. Any other questions to Dr. Medhat? Yeah. Here is a question from Ms. Aisha Khan. What CT value cutoff is used in your laboratory for determining positive or negative? Is it the same cutoff for all targets, S, ORF, and gene?
Yes. So these are determined by the manufacturer. We don't get to decide on those. So according to the manufacturer, anything less than 40 is positive.
Okay. I understand that.
For all targets.
Okay. I think also here with us today, I think Dr. Ashraf joined our presentation, and would love also if Dr. Ashraf would like to comment, please. Go ahead, Dr. Ashraf.
Thank you, Fadi, and allow me first to thank you, Dr. Fadi, and also Sally and all involved staff for organizing this nice webinar. And I would like to thank Dr. Medhat for this really excellent presentation with fantastic slides, many slides that need a huge effort done by you, Dr. Medhat. Thank you.
Thank you.
And I would like to highlight and thank also that you show us very clearly our role in the Transplant Immunology Lab to support and help in this difficult crisis, support testing and managing corona cases in the hospital. This is very important for our society as well. So I want to just make also a comment that now we have in the market and ELISA for IgG antibody against S1 and S2 antigens of SARS-2 viruses. And the company was Diasorin company. They make comparison between the results of this test and the neutralization test, and they found concordance of 95%. So that we have ELISA technology, which is a little bit that we can compare with the neutralization antibody and neutralization assay. This is very important, I think, for a laboratory who have not S3 laboratory for cell culturing and neutralization assay. And my questions, do you use these tests antibody specific against S1 and S2 in your laboratory, Dr. Medhat?
So we use combination of strategies. We didn't historically have the Diasorin instrument, and it is about $100,000 instrument. So, but we had the Abbott Architect that is nucleocapsid, which is not great, but it is IgG only. And we also have ELISA, the automated ELISA platform that we use, and we use actually a combination. We use epitope, we use creative biolab, we use the Euroimmune, and some of them are S1 and S2.
Thank you.
Sure. Anybody has questions in the group, please? Comment.
السلام عليكم.
عليكم السلام ورحمة الله. دكتور زين.
فادي كيف الحال؟ السلام عليكم مدحت and good. But my question, I guess, we've had this, discussions back and forth so many times.
Yeah.
Appreciate always your input and feedback. We have here a different strategy in the UAE. We're going into actually mass screening, so it's not only targeting symptomatic patients. We have drive-throughs all over the UAE, and roughly we do really more than 30,000 a day tests. So we experience. I'm not sure what the phenomena is, but we experience a good percentage of. I'm not going to call it false positive because it depends when the second sample is taken, but there is a good percentage of the first samples that become negative. Now, it could be contamination, although we found that this is actually happening across many different labs, not only coming from one lab. It could be that the patients are really with low viral loads, that eventually the second sample turns negative. I'm not sure, just want to hear again your perspective and others. And
so this is really a great question, but I would say it really depends on the context. Why you are testing these people? What you're going to do with the result? This is really what determines. So the context I specified, we test every patient who's going to be admitted to the hospital. So our goal really is to have zero, So if it comes positive by antibody, in our case, which happens, we look at the PCR. If it's negative, then we would repeat it and make sure why it is positive. So it really depends on the stakes, what's at stake. If you're doing it just for prevalence, as I said, it doesn't matter who's infected and who's not, then the false positive and false negative probably going to cancel each out, and you're going to come up with the similar. But to make decisions on individual cases with the antibodies, with our understanding at this point, is really very hard. Because as I showed, you may have someone who has antibodies who are still shedding the virus. So really, just doing antibodies is not going to be very helpful in making these decisions.
No, correct. I agree with you. Even the PCR now, there are more and more reports that the previous recommendation is to have two negatives in order to discharge people, and now there are studies from Singapore and South Korea, and even here started to be implemented that if asymptomatic and have been several days post, then they can be discharged without even a PCR test. One of the is because of the fragments, dead virus RNA that persist for so many days after being cleared, and cultures turn out to be negatives for the virus.
I agree with you. There are a number of reports really coming out to this effect at this point in time.
Very nice. I think Dr. Rabab also is part of the people here. If she, I would love if she can comment something. Dr. Rabab, please. The floor is yours. Is Dr. Rabab hearing us? Is not. She showed. Anybody has questions, comment, please?
Since Dr. Ashraf is raising his hand.
Oh, Dr. Ashraf is here. Please, Dr. Ashraf, go ahead.
No, actually, I have raised it at the beginning, but I think Fadi overlooked.
Oh, sorry. Okay, there is another question here. Please, go ahead.
I want just to comment also the study which you showed, Dr. Medhat of Dr. Wang, published in the JAMA about the nasopharyngeal swab and oropharyngeal swab, that the one is 63% and the other one is 36% or 35% sensitivity. I think we should know that here they use maybe not advanced technology, and when you use different technology, not Chinese technology. I want to see this, for example, German technology, or even American output, for example, technology. We have much more sensitivity and less more false negative and false positive results, which range above 80%, not 63%. I think this depends on the machines which were used and in China.
Very well taken. I think one thing I think this is a great point, that these percentages gonna vary based on technology. And probably if you look at number of reports, everyone is gonna give different percentages. But I think the take-home message here is that really the percent positivity is gonna depend on the type of sample. So this is very, very important. And none of the sample is gonna give you 100%.
Yes.
So yes, so 80% is a significant improvement over 60%, but you're still missing big chunk of patients.
Yes. Fadi, allow me also to make the small comments for the question of Dr. Zain.
Please go ahead.
This new policy now to discharge patient without testing them with PCR. This also related that more and more reports and studies showed that the patient, they shedding the virus just for a few days, not more. They are infected probably for 1 week, maximum 10 days. They are infectious. And this is behind also this policy. I think this is a new virus, and we learn more and more about this virus.
Thank you, Dr. Ashraf. Here also we have a question to you. It's just raised by Ms. Huda. Thank you for a great presentation. Which source of the plasma is better? Plasma of recovered very sick patient who was in ICU with ventilator support, or from mild symptoms?
That's a very difficult question. I don't think there is enough information to make firm conclusion. But I remember one of the studies I read is that when they looked at characterization of neutralizing antibodies, the titer of neutralizing antibodies, they found that patients who had lower level of neutralizing antibodies, they had more protracted course, they had more severe illness. So it seems like the more robust immune response you make, that then you would be protected and you will get less severe disease. So, but however, it's a continuum. You know, it's not like patients are in buckets, those who are severe and those who are mild, and so they're gonna progress. So at what point you collect the plan? That's a very important question. I'm not sure we have the answer for it.
Allow me also to make comment, Dr. Medhat, here.
Please.
We have made the study exactly to answer this question, 2016, in MERS coronaviruses, and we published it in Science. At that time, we found that the immune response and the neutralization antibody in severe ill patients was much more higher than patients with mild symptoms or the asymptomatic patients. Very clear correlation. I speak about MERS coronaviruses. With this virus is not clear, but probably is similar.
But you see, this is the problem. It makes sense that the more the exposure to the immune system of the virus, the more robust the immune response is going to get. But that flies in the face of studies showing that the more immune response, it's the egg and the chicken situation. If you have more robust immune response, then probably the virus is not going to cause as much damage. But having so much damage is going to make the immune response robust. So that's why I say it's a complicated question to answer.
And just one question. So for, I'm not sure if you already mentioned that, what is the best, from your experience, to test these? I know neutralizing antibodies is the most ideal, but from these commercial kits, Euroimmune or Epitope or Diacerin to measure, for these convalescent plasma collections.
I really cannot. I don't think we can answer this with the confidence. There is a promise that the diazorin antibody kit that measures antibodies to S1 and S2 and shows above 90% correlation with neutralizing antibodies. That might be what we are looking for, but I don't have experience with this platform. So maybe Dr. Ashraf can comment more on that.
No, we haven't till now. We wanted to. We have ordered it. We wanted to establish it.
Yeah.
Mm-hmm. Okay. Any questions also? Maybe someone now will ask question from the technological advancement. You touch about NGS now. Probably now your clients across the whole organization, infectious, ICU physician, and everyone will be really keen about the turnaround time. How you see now touching, doing it by NGS, looking at the turnaround time, see the versus the clinical demands, which is the admission patient. How you look at this?
Okay, so actually we have the NGS kit here and we are testing it. We don't envision this to be first line because of the turnaround time. But for patients, for example, who seem to have severe disease and not responding, you know, in a young patient that doesn't have comorbidity. So this is one that you want to test, you know, see the sequence and see if it is anything different. So I think of it as a more reflex test to answer specific questions rather than screening too.
Okay, sure. Here, there is a question from someone. Thank you, Dr. Medhat, for a great presentation. Is there any studies for getting plasma from animals? Same concept of xenograft for COVID-19 treatment. May antibodies are better and protective from animals? Your comments?
I don't know. I don't think there is shortage. I mean, we have millions and millions of people who are already infected and recovered. So I'm not sure there is a shortage that will push us in this direction.
Sure.
I'm not aware of a study to this effect.
Fadi, if you may allow me just one last question from my side. So I'm not sure if, again, you mentioned this, Medhat, the antigen assay is another one coming now more. There's one FDA approved under the Emergency Act, and there are more companies coming from South Korea. We validated one here, and we've got I would say better than what I was expecting in terms of sensitivity, and specificity was very good actually. So just want to know your experience, if you guys have looked at any company or not.
Yeah, actually we haven't looked at it. So if I may ask you, what was the motivation to do this versus PCR?
Mainly the quick turnaround time, especially for ER settings, to give a quick answer to admit or to discharge, because really at some point there was a need for a quick answer was very critical. And again, what we found that it depends on the cohort group. We've done a more extensive validation and try to correlate even with the level of CT values to see where it can give you. And for symptomatic, it's actually very good. Yeah, sensitivity more than 80%. But as you go more into more asymptomatic screening, then sensitivity goes less and less. And the other thing is I was going to say something. Yeah, the other thing is, again, there are studies that usually with the low CT value, less than 25, then these patients are infectious. They transmit and shed the virus compared to those with high CTs. So we're trying to make these overall correlation to see if it can be more used for other setups, but currently we're just trying to validate it for symptomatic ER setups.
Yeah, sure. Dr. Medhat, here there is a question. Thank you, Zain, for your comment. also now here is there's a question from Hanouf saying, thank you for the informative presentation. My question is regarding NGS. If it can take 1,000 samples done in 18 hours, could it be proved effective for asymptomatic screening rather than real-time PCR? Would it show higher sensitivity?
It would. It would be higher sensitivity. So that's another, Thank you for reminding me of that. So that's another application we're thinking of it.
Very nice. Very good. Oh, another question here, Doctor. We have read reports saying recovered patients may get reinfected. Why recovered patients can get infected if they have already produced immunity? In addition, studies show that there is many strains of the virus. Can we use the same plasma?
So, I mean, these are like bunch of questions together. So let's try to disentangle them from each other.
Okay,
so
it's yours.
One, I try to emphasize that not everyone get infected develop antibodies. Not everyone who get antibodies develop neutralizing antibodies. Not everyone who get neutralizing antibodies get effective neutralizing antibodies that are protective. So we really need to keep this in mind. That's one thing.
Good.
Another thing is the limitations and sensitivity and specificity of the assays. So saying that someone became negative and then redeveloped it, is it really negative or is it false negative? If I tested today, I had symptoms, okay? And I really never cleared the virus. And it became low and it became negative. But actually, I continued to shed the virus. And now I'm testing positive again. So I'm not sure that this even qualifies as reinfection. So that's another possibility you can keep in mind. I read a Korean study that is still in the preprint arena. It is not published yet, but they did something very interesting. They looked at a couple of hundreds or maybe several hundreds of patients who, quote unquote, got reinfected. And what they found is something very interesting. The majority of these patients, more than 50%, were asymptomatic or had mild symptoms. And in none of them, actually, they were able to culture the virus. And in none of them, there was evidence that they infected anyone independent of other factors. I mean, like, it wasn't the case that there was a family member that only got exposed to them and got infected. Mm-hmm. So I'm not sure how much different strains play into this. As we said, you are really getting to the heart of how effective is convalescent plasma when it could be from a strain of virus different than the patient you are infusing it to is having, right? That's really the heart of your question. But if we even not able to assess the effectiveness of convalescent plasma altogether because of lack of controlled randomized trials, even if it is from the same strain, then it becomes a really not answerable question at this point in time, however different strains play into this or not.
Sure. I hope.
Sorry, one.
Please go ahead.
Fadi.
Go ahead.
Thank
go
you.
Ahead.
I enjoy always talking to Medhat.
Go. Challenge him, please. Challenge him.
Thank you. No, I just, so what do you think? There's one study just published recently about temperature and virus stability. What do you think?
Only time will tell. We don't know. Yeah, I think we will need to see this reproduced in other studies.
And the one way, there's, I mean, more from Italy, they're saying that whatever we see right now in terms of, the virus itself is less compared to what they were seeing 2 months back. Is this what you guys are seeing in the US as well?
What do you mean, like new cases, or what is less?
No, like the the severity of the cases. Maybe they think that the strain of the virus is less aggressive compared to what it was 2 months back.
I think that's a general impression I'm having from just looking. I get everyday reports of how many patients in the hospital, how many patients in the ICU, how many patients on ventilator, how many new cases, how many deaths. And we see clearly that number of deaths is going down, number of patients who need ventilator getting down. So I could take this as a measure of lower severity of the disease. It's just I'm not sure how this rises from the level of anecdote to level of evidence.
Okay. Very well. Any other questions, guys, from the audience? Please don't hesitate. Jump in and shoot it up. Any other questions? Here we are seeing, still we have 34 participants with us. Please, any question before we conclude? Looks no questions so far. Looks no questions. So I would like now to conclude and this presentation, fantastic webinar by a fantastic guests who really always show us the art of the science. Thank you so much for the time you spend with us this week.
Pleasure.
And I know whenever we ask you, Shah, thank you for the audience, for the team who participate, make this presentation really engaging. And thank you everyone. Looking forward to seeing you for future webinars, which should be coming after within next 2 or 3 weeks. Thank you so much, and I wish you a great
Thank you for having me. I really appreciate it.
Thank you. Thank you, Fadi. Thank you, Medhat.
Thank you.
Yeah, thank you all. Thank you.
Thank you. Thank you, Zain. Thank you.